Racist or racial or race health inequities in America and why single payer, also known as national health insurance or expanded and improved Medicare for all, is a necessary part of the solution. As I said, I'm a volunteer with Physicians for National Health program in the New York Metro chapter, but I've given talks nationally as well as throughout New York on a variety of single payer topics over the years. Since my retirement, I've sort of become a social justice activist in a variety of areas beyond just single payer. I was blessed to be able to speak as one of the few white speakers at a Black Lives Matter rally a couple of years ago in New York. So since we're not covering in detail what is single payer, I just want to make sure we're on the same page as to what single payer is before going into the racist disparities issues per se, and then I'll bring it back to why single payer therefore is part of the solution. So when we say single payer, we're talking about publicly funded but still privately delivered national health insurance. In other words, it's the financing of the healthcare system, not the delivery. So this is quite distinct from, let's say, the United Kingdom, which has a national health service. So in a national health service, the doctors, the hospitals are all direct government employees. And an example of that in the United States is actually the U.S. military with TRICARE and the VA system. But that is not what's being proposed here. So what's being proposed here is to continue the current same mix of mostly private, but some public system healthcare delivery, private doctors and hospitals, but publicly funded insurance pool, replacing the current system of premiums, copays, deductibles, and other out-of-pocket costs. And that would be paid for through progressive taxation. So replacing a regressive tax in effect of premiums, copays, and deductibles with progressive taxation. But the private delivery, and in fact, I would suggest it's the best of capitalism, because now you would have all of the doctors and hospitals competing to get patients, since all patients are covered and all the doctors and hospitals take the coverage. It would actually be the best of free market. So again, all the providers take the same national health and comprehensive insurance, and all the patients, everybody in America has it. It's very important to be clear that this is not just the current Medicare as it is, but expanded to age 0. But it's also a massively expanded and improved benefits package. So it's comprehensive for all medical, mental health, dental health, hearing, vision, drugs, devices, and very importantly, long-term care, which is a huge burden on people nowadays and is not well covered at all. So that would be both home health care, preferably, and residential long-term care where needed. Prepaid by progressive taxation, as I said. So the net effect is that it would be less expensive for approximately 95% of persons. So in effect, you would not only be getting guaranteed comprehensive coverage with the security that you always have it, regardless of changes in your employment or changes in your life circumstances, as well as the increased freedom to choose any doctor, any hospital, no more narrow networks. But in addition to that, for 95% of people, it would in effect be an increase in their income. So the economic argument for it is the current system with fragmented private for-profit health insurance, the current system is inherently perverse incentives from an economic point of view. The companies make money by either avoiding sick people under their pool or paying for the least amount of care possible. And this is inherent and it cannot be fixed. And I'd love to go into greater detail on that. The link at the bottom here is a 1-hour talk that I give on single payer itself. One of the things about single payer is we usually have a slogan about everybody in and nobody out. It's not just a slogan, it's actually an economic necessity for how you create an insurance pool with everybody paying in a little bit all the time, because at the point of service, costs are too high. And that's actually the fundamental reason why you have an insurance pool, which has been perverted with fragmented and for-profit. Under single payer, there's pretty much universal agreement across the political spectrum by economists, total cost savings and cost shifting. as we said before, less expensive for the vast majority of folks. And at the end of the day, it's really the only way. If the goal is to cover everybody, reduce total system costs, and reduce the cost to most individual families, businesses, employers, if that's the goal, then pretty much single payer is a necessity. The moral argument is, do we consider healthcare to be a private for-profit commodity like some widget du jour? Is it like your iPhone or TV? Or is it a social need and a communal good? And we sometimes use the example of the fire department. So when you've paid for the fire department through your taxes, and if you have a fire at your home, they come and put it out. They don't ask you for a copay. They don't ask you for deductible. They don't ask you if you're in network. They don't ask you for additional money. They come and put the fire out. I want to emphasize here, because of the nexus between economic and social class and race and ethnicity in America, but really for everybody, the fact that there's a huge financial burden of healthcare under the current system, and it is paid as a higher percentage of income by people who have lower income. That's what we call, in economic terms, regressive. That the people of less disposable income, have less total income, are actually paying a higher percentage of it to healthcare than the higher income people. So the dark green here shows the status quo. The cutoff at 139% of federal poverty level is the Medicaid cutoff. So, and this is only, again, for people pre-65, so pre-Medicare in age and post-Medicaid in terms of income eligibility. And what we see here is that even a strong public option, while it shifts the curve down, it doesn't change the shape of the curve, whereas single payer flips the curve so that lower income folks are paying a lower percentage of their income, and the higher income folks who have more disposable income, in other words, left over after they pay for the other necessities of life, pay a higher percentage. Another way of looking at it is in this slide, again showing that it's only when you cross the top 5% of earners, which was $462,000 in family income back in 2013, that people begin to pay more. And so, in effect, single payer is literally increasing the income for quote unquote the bottom 95% of households. So let's stop for a moment and think about the United States compared to other developed capitalist democracies. Looking across the OECD countries, you see here that the United States is amongst the most unequal, and certainly the most unequal amongst those countries that we would otherwise consider our peers. The only countries with greater income inequality are Turkey by a hair, Mexico, Chile, and South Africa amongst the developed countries. And off to the left, you see countries like Denmark and Norway, for example. So we want to bear in mind that the United States, just overall, is one of the most unequal countries in its inequality by income in the developed capitalist democracies. Now, when we talk about the political and social and economic determinants of health, it's important to acknowledge the very special and unique place that race and racism has in the United States, going back obviously to 1619 in the beginning of slavery, chattel slavery in the United States. But there are very few things that are truly diseases that associate with race per se. Race primarily is a social and economic construct. Its biological underpinnings are relatively minimal. And a lot of the racial disparities, whether it's in healthcare or anything else in the United States, show up in effect as social economic class, if you will. So it's the racism, not race, if you will. So we have differences in disparities by wealth and income, by workplace conditions, job type and autonomy, residence, household size, various factors around land use and physical environment, means of transport. We saw that in New York City with COVID, where persons who had to travel by bus or subway or the people working in the bus and subway system were amongst the first hit in the COVID waves and the most hit in COVID waves. Those of us privileged to be able to work from home or drive in our own cars were less hit early on. And obviously other access to education, childcare, nutrition, and just basically the micro and macro aggressions of living in America as non-white. It turns out that literally the stress of living as black in the United States is part of the reason, and there's multiple studies in the peer-reviewed literature, multiple reasons why, for example, heart disease is higher and earlier incidence in African Americans than white Americans. In addition, access to health care, which is what the single payer part gets to, is also obviously a huge factor. So life expectancy of the wealthiest 1% of men in the United States is 15 years longer than the poorest 1%. So yes, income makes a difference. Annual healthcare spending is higher for white U.S. residents than others, in part due to the imbalances in private coverage insurance. United States spends more compared to our peer countries. We spend more on healthcare, but with worse outcomes. So what you see here on the left in the purple dots is the United States slowly diverging away from the rest of the G7 developed capitalist democracies in the world in life expectancy. So we were roughly middle of the pack in 1960, and we are now substantially worse than the rest of those countries in 2018. And even as we have diverged in the wrong direction on outcome as measured by life expectancy at birth, compared to those other countries, we are spending more and more as a percent of GDP on healthcare. So we're paying a lot more per the the light blue line on the right, than we get worse outcomes. Now, what are some of the components of why we spend more with worse outcomes? Well, one of those components, I should say on the left here, what you're seeing is an analysis of if you took all of that premature mortality in the United States, all of those excess deaths over the years, it adds up to as many as 500,000 excess deaths in 2018 because of our poorer life expectancy compared to the other G7 countries. And what you see on the right here is how that breaks out by sort of standard race ethnic groupings in the United States. And so you can see that Native Americans and African Americans have higher relative risk, higher excess mortality by age group compared to whites. And interesting, actually, Latinx or Hispanic Americans and Asian Pacific Islanders are actually, at most of these age groups, actually have relatively better life expectancy than whites. One reason for the Hispanic is thought to be a combination of both a healthy immigrant effect and a healthy worker effect, as well as healthier lifestyle in first generation. So if you look at black compared to white Americans, black life expectancy is 3.5 years less than whites. And if you look at for current 40-year-olds going forward, it's 6 years less. Higher rates and more likely higher rates, earlier onset, worse outcomes from diabetes, HIV/AIDS, heart disease, cervical cancer, infant mortality, maternal mortality, and also persons of color are more likely to be uninsured, more likely to have past medical dues, bills, more likely to have a shortage of access to primary health care, and their hospitals are more likely to A, close, and B, to have less infrastructure associated with the hospitals in terms of services, and we'll see some of those. So black life expectancy, 3.5 years shorter than white lives. This is life expectancy at birth. For black Americans born in 1980, this is that age 40, more or less, living 6 years shorter than whites in terms of life expectancy for persons born in 1980 as opposed to overall. What we see here is spending. So the United States spends less on non-whites than it does on whites in healthcare. So the pale blue here is healthcare spending per capita for whites by age group, blacks, Hispanic, and other. And again, in every age group, whites have more spent on them than others in America. Until age 65, in other words, until Medicare kicks in, people of color are more likely to be uninsured. This shows the percentage of persons without health insurance, age 0 to 64, in 2017. So let's remember this is after the ACA has kicked in, with only 7% of whites being completely uninsured, putting aside for a moment that insurance doesn't guarantee you access to care, given that 75% of doctors nationwide don't take Medicaid. And there's a lot of other factors in terms of access, also in terms of not actually being able to pay premiums, copays, and deductibles and out-of-pocket costs, even if you're nominally insured. Lots of reasons why just having health insurance isn't the be-all and end-all. But within that, it is simply the case that whites have the lowest uninsurance rate. Similarly, past due medical debt is higher amongst Black Americans and compared to white non-Hispanics, although it's pretty darn high for everybody, which says something. Medical conditions that shorten Black lives, so just looking at specific medical conditions that make up some of these issues. Breast cancer in Black women compared to white women, more likely to present as advanced disease and with a lower 5-year survival rate. Similarly, infant mortality rates higher in African Americans than white Americans, and that's both post-neonatal and the later no prenatal care categories. What you see here is maternal deaths per 100,000 live births. There was a time when we thought we were going to be able to almost eliminate maternal deaths in the United States. We've actually gone in the wrong direction since I was in medical school on that. There was a time when it was considered that any single medical death was itself a morbidity and mortality rounds event, that there was a sentinel event, and each and every single one should be treated as if it were an error in the system. Certainly at least 63% are considered preventable, and as you can see here, far higher rates in African Americans, Native Americans. This is basically just showing across the race categories in the United States, but also comparing to Canada. So pointing out here that Canada has half the maternal mortality rate of white non-Hispanic Americans, 12.7 compared to 6.3. So again, just a sense that there is just something in our system that is broken. It's broken for white Americans. It's even more broken for African Americans. Before COVID, I don't have a lot of post-COVID slides here, but before COVID, as we were seeing before, life expectancy for African Americans, Native Americans was lower. Since COVID, the mortality gap between Black and white people has widened by more than 50%. And that Hispanic Latinx life expectancy has dropped precipitously by 3.5 years just during COVID, given the high impact in mortality on Hispanic Americans. Some additional factors, there are so-called trauma deserts where just looking in Chicago, Black majority census tracts in Chicago are 8.5 times more likely to be more than 5 miles away from a trauma center. This is from the New York City, highlighting some data that we looked at in part during COVID. So we had a lot of hospital closures prior to COVID. Those hospital closures prior to COVID over the past 20 years were disproportionately in minority neighborhoods. And if you look here, just by the different boroughs within New York City, the hospital beds per 1,000 population is much higher in Manhattan and much lower elsewhere. and they were still trying to close hospital beds in the outer boroughs during the COVID pandemic. So again, a disparity in structural access. We want to talk about structural racism. Here's a literal case of structural racism. So hospitals that serve predominantly Black and Latinx populations have less capital funding for their building and equipment, both total assets as well as new purchases, um, compared to those that are serving predominantly white persons. Similarly, the odds that a service is available in minority serving hospitals versus white serving hospitals is less. So again, if you want to talk about structural racism, this is literally structural racism built into the structure of the hospitals. This is something you're probably aware of as current medical students. This is looking at the percentage of Black, Hispanic, and Native American in the U.S. population overall, in the bars on the left, 13.4, 18.3, and 1.3% respectively. By comparison, the percentage of racial composition for physicians, 13.4 for African Americans overall, 5% of physicians. And you can see similarly even lower for dentists, a little bit closer to the U.S. Population in the case of nurses for African Americans, although not for Hispanic Americans. So, again, another way to look at the racial or racist disparities in our healthcare system. So what's the evidence that single payer would make a difference? I mean, there are so many other reasons for why there are disparities in terms of income and living environment and educational opportunities and job opportunities. So what's the argument that single payer would make a difference? Well, first of all, let's look at some of those medical conditions that shorten Black lives. So we have a category, this has been worked out by ICD-9 coding and looking at what the diseases are. So we have a category of diseases that we consider to be amenable to medical prevention or treatment. Not all diseases are preventable. Not all diseases are treatable. If you've ever had a class that goes into why screen for disease, you've probably seen some of the analyses around this. But if you look at the diseases that are particularly notable for disparity in Black lives compared to white lives, about 86% of them are amenable to medical prevention and treatment, suggesting that improved access to healthcare would in fact make a difference. As we noted before, percentage of persons who are more likely to be uninsured is higher amongst African Americans. Now, this is a wonderfully important slide. So this was a ranking that's done on a regular basis. It's a combination of the OECD internationally and the United States Institute of Medicine. And they've looked at 17 countries on an ongoing basis, members of the OECD. So again, these are the wealthy, developed, capitalist democracies around the world. Not just in Europe, but, Japan, Taiwan is in there too. So if you look at those countries on a range of parameters, and there's 17 countries and a range of parameters, the United States is at the bottom of the rankings of the 17 overall on just about all of the parameters. So we're somewhere between 17th out of 17 and 15th out of 17 on all of these parameters until you get to age 65. And all of a sudden at age 65, up, the U.S. relative ranking goes up. And finally, when you actually get into the 80s, finally, for the first time, the United States actually does have what's considered to be amongst the better healthcare systems amongst the developed capitalist countries, as opposed to being 17th out of 17. Well, what happened at age 65? Well, obviously what happens at age 65 is that for most persons living in America, all of a sudden they become eligible for Medicare. And they become eligible for Medicare more or less equivalently, regardless of race. And that's important. Another suggestion that single payer access to healthcare would make a difference is this study, which looked at what counties, if you look at all of the counties that have a significant population across the country, and I have to say county, it's a whole separate talk, but county is a terrible unit of measure because of the difference in population and size and density. But if you look at the counties that have a large enough population and large enough African American population that there's reliable mortality statistics in them. If you look at all of those counties, 1,307 of them, and you say, well, in what counties are there possibly the same or lower mortality for African Americans than white Americans? And in particular, if you look at men, African American men and white men, which are the counties that they are the same or better for African American men than white American men? So you can see overall in the red that black men have a much higher death rate per 100,000 than white men overall. That's the black compared to the teal. But you do see one line in the black line there is showing what the numbers are for the 66 counties out of the 1,300 where the black mortality is better or equivalent to the white mortality. So what is the common factor in those 66 counties? Well, it turns out that those are the counties that have a high military population due to an adjacent in-county or adjacent county military base, and which of course also then goes with a high retirement in terms of access to the VA. So it seems like having a high percentage of your population who are in the military or have or the VA begins to equalize or have some association in this ecological study to reduce the difference in mortality between white and black. There's a bunch of other studies that again support the idea that having equivalent healthcare coverage makes for reduced disparity or equivalency. So there is amongst African Americans post-MI deaths between overall and then after adjusting for insurance, some of the differences in post-MI mortality go down is the first box here. Dialysis, which was really one of the first carve-outs for a disease where they just said, okay, we're going to make universal coverage for persons with renal failure needing dialysis. We're just going to make that one disease universal coverage for everybody, regardless of age. So if you have renal failure, you're automatically covered for renal dialysis in the United States. It's sort of universal single payer coverage for one disease. If you look within the population of persons receiving dialysis for end-stage renal disease, it turns out actually that blacks do a little bit better than whites. If you look to the Veterans Administration system, so in the VA, there's a couple of things. First of all, the coverage is equal, right? So whites and blacks in the VA are getting the same VA coverage. The VA has done something else. They've actually taken out of the standard medical note the routine use of black or white to describe somebody. So at least when I was in medical school and early in residency, I was always trained, you know, so-and-so is a 38-year-old black female with yada, 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 or so-and-so is a 40-year-old white male with yada, yada, yada. You're not allowed to do that unless there's an actual specific reason in the VA note system. So when you're describing somebody and you're saying, oh, well, are they meeting criteria for coronary bypass surgery? The note doesn't include whether they're white or black. And African Americans do equal or better in the VA system than white Americans. What about our current system versus a public option? And so all of what I've just described are reasons to think that increasing insurance coverage decreases the disparity as a necessary, albeit not sufficient, part of getting rid of the racial or racist health disparities in the United States. So, what about our current system? We're adding a public option to our current system compared to single payer Medicare for all. So public option's not universal. It still leaves millions without coverage. It doesn't help with the churn, the administrative complexity of going on and off and on and off. It still leaves people with copays and deductibles and premiums, and out-of-pocket costs. Single payer gets rid of all of that, as we've seen. Many of the public option proposals, and especially when you start getting to things like Medicare, so-called Advantage, where they have, again, copays, deductibles. You need to go through jumping through many hoops in terms of getting prior approvals for care. And you also wind up with limited networks of care and may have to travel longer distances to find a provider that's in your network. And they don't cover all kinds of things. Doesn't do anything to equalize funding, direct or indirect resources to underfunded facilities. We saw the differences there in part between the hospitals and clinics that serve black neighborhoods or poor neighborhoods compared to white neighborhoods or rich neighborhoods. And single payer not only equalizes the fee-for-service compensation for care, but it also proposes to have a certain degree of global budgeting where the hospital is funded on the basis of the community needs and demand for care rather than on a fee-for-service basis for elective procedures. We saw how ridiculous it is to have hospitals reimbursed on the basis of having their major source of funding being elective surgery on a fee-for-service basis during the COVID pandemic, when the same hospitals that were overwhelmed and opening up new ICU beds were turning literally in the Bronx, where my wife works, were literally turning conference rooms and libraries into ICU beds, and at over 150% of census, with much more intensive levels of care, and at the same time we're losing money. So they had more patients, more sick patients, more intensive patients than usual, and because those patients were ICU sick with COVID, dying of COVID, and they weren't semi-elective surgeries for higher paying things under our current system, the hospitals were going under a financial strain. That's ridiculous. I mean, the hospital should be getting more reimbursement if there's higher demand on them. It just makes no sense. And again, public option just leaves the same fragmented, multi-tiered system. And a public health system and universal national health insurance puts everybody on the same footing. I mean, if a poor white person and a poor black person and a poor Hispanic person are all in the same healthcare system as the middle class, upper middle class, and wealthy, well, the upper middle class and wealthy have an incentive to keep the system good. So there's numerous studies that show what the excess deaths due to uninsured and underinsured in the United States are. Single payer advocates often cite the 68,000 excess deaths per year. I actually like to cite the 18,000, 6% higher mortality. That was the study that was done by some conservative researchers, specifically trying to debunk the high number. And try as they might, the debunking study still showed 6% higher mortality due to uninsured and underinsured and 18,000 excess deaths per year. That was the debunking study by conservatives. So to my mind, that's almost as strong an argument as any. So we saw with the establishment of Medicare back in 65, along with Medicare and Medicaid, we saw that there was a transformation in the U.S. healthcare system for the better. One of the transformations was they were able to leverage Medicare to desegregating the hospitals around the country, or at least officially desegregating them. There's a wonderful documentary about an hour long called The Power to Heal on this. It was derived from a book. The references are there. And so for how Medicare was used to leverage the more or less the official segregation of hospitals. Famous quote from Dr. Martin Luther King Jr. of all forms of inequality and justice in healthcare is the most shocking and humane. I want to play this movie for you. One moment.
Among high-income countries, universal health care is standard, except here in the United States. Why is
I just want to check in. Is that coming through for everybody? Can somebody unmute and confirm? Thank you.
that? Here's a reason that you may have never heard before. Our failure to pass a national health plan is largely due to America's history of structural racism. In 1945, Democrats were in control of the House, Senate, and the executive, and President Harry Truman decided to push for national health care. That year, 64% of Americans supported a national health insurance plan. Support in the states' rights South, which was heavily Democratic at the time, was even higher than the national average. Seem too good to be true? That's because Truman's proposal would have expanded health coverage through Social Security, which at the time explicitly excluded agricultural and domestic workers. That meant 60% of black men and 80% of black women were not eligible for the benefit. However, the push for national health care coincided at a time when challenges to Jim Crow and discriminatory provisions in federal programs like Social Security were also underway. In 1946, Truman established a Civil Rights Committee, which desegregated the military and banned discriminatory hiring practices in the federal government. Southern elites began to link new proposals coming out of Washington with threats to segregation in education, healthcare, and housing. The possibility that a national health plan would desegregate the healthcare system and institute a significant transfer of wealth from whites to blacks caused Southern support to plummet from 66% in 1945 to only 22% 4 years later. Southern elites were a core constituent of the Democratic Party at the time, and nothing could be passed without them. In 1949, around the time every other wealthy country was moving towards universal health care, the Democratic coalition fractured and Truman's plan in Congress died. In 1964, the NAACP won a landmark Supreme Court case requiring hospitals built with federal funds, which was most of them, to desegregate. A few months later, the Civil Rights Act was passed, reinforcing this mandate. Passage of a true national health plan was still blocked by Southern Democrats in the 60s, since after the Civil Rights Act, this would have meant desegregating the entire healthcare system. So in 1965, the Southern delegation finally came to the table to negotiate the creation of two groundbreaking, yet limited healthcare programs: Medicare, which initially covered only seniors, and Medicaid, a state-run program for certain groups of low-income people. The Dixiecrats ensured that these programs were designed as much as possible around the racial hierarchies in the healthcare system. For example, Medicare is split into two parts. Part A, the part that covers hospital care, requires no premium. Medicare Part B, the part that covers physician care outside of a hospital, does require a premium. Why split Medicare into two parts? Part B was designed this way so that physicians' offices in the South could claim that it was a voluntary insurance program, not a direct government payment, and continued to racially segregate their offices and refuse black patients. And why was Medicaid created as a federally funded but state-administered plan, while Medicare was administered by the federal government? This compromise allowed Southern states to discriminate against low-income people of color in terms of eligibility as well as benefit levels, and this also dramatically slowed the desegregation of nursing homes. While Jim Crow laws no longer exist, the impact of structural racism on our country's healthcare system has been profound. People of color are still overrepresented in states that have poor safety nets and strict Medicaid eligibility requirements, and new waves of immigrants, particularly Latinx, have fallen into these systems of racial inequity created for African Americans. True national health care, like Medicare for all, was blocked by segregationists during the post-war period when the rest of the developed world was establishing healthcare as a right. By the 1970s and 80s, a large healthcare industry and lobby had emerged, making passage of national healthcare more difficult and likely requiring a massive social movement. It's time to atone for this ugly chapter in our history by building that movement and guaranteeing everyone healthcare from cradle to grave.
So, thank you. Just want to point out, this is a nice little model from our general single payer talk on the fragmentation and bureaucratic administrative complexity of and waste of our current healthcare system, and the simplification that would be coming with single payer. I would suggest that single payer, expanded, improved Medicare for all, national health insurance would increase freedom, to use a popular buzzword. I think it frees you from corporate constraints, restraints on your personal healthcare decisions. It increases your freedom to choose any doctor in any hospital, no narrow networks. It increases equality, a pathway to end racial bias in the funding and delivery of care. It increases justice in terms of being progressively paid for everybody, regardless of race, ethnicity, income, wealth, employment, status, everybody living in America. And it increases your security, that you always have it, cradle to grave, regardless of any changes in your job or changes in other life circumstances. Again, I'm with PNHP, and my giving a talk that's just on single payer is available at that link. And I think I'm done